Welcome back to Decode Healthcare. I'm your host Harshal, and today's explainer is an absolute masterclass. We're diving deep into the highly specific, incredibly complex CPT rules for neonatal and pediatric critical care. If you code for the NICU, the PICU, or handle critical care transport, you know firsthand that these codes are an absolute minefield of age tiers, weight brackets, and global bundles. Getting them wrong doesn't just result in a denial, it opens you up to some severe compliance risks. But hey, don't worry. By the end of this explainer, you're going to have a crystal clear understanding of exactly how to navigate CPT codes 99468 through 99480 with total confidence.
All right, let's take a quick look at our agenda for today. We'll be covering neonatal critical care rules, pediatric critical care tiers, weight-based intensive care, critical care transport, bundles and transitions, and finally, those top audit red flags. Let's get right into it.
Starting off with Section 1, Neonatal Critical Care Rules and the Per Diem Global Bundle. So, the absolute most crucial concept to grasp right out of the gate is this. Neonatal and pediatric critical care codes operate on a per diem, 24-hour global billing structure. This is literally night and day from the hourly, time-based critical care codes you might be used to in the adult ICU or the ER. When you bill a neonatal critical care code, you're billing for the entirety of the care provided by that physician or any physician in the exact same specialty and group practice for that entire calendar day. You do not count minutes. You're just evaluating the patient's age and their clinical status for that entire 24-hour block. For our youngest critically ill patients, and by neonates we mean 28 days of age or younger, you're going to use CPT 994068 for that very first day they're admitted to critical care. Then for every subsequent day they remain critically ill, you just drop in 994069. Remember, these are per-day codes. You report them exactly once per calendar day per patient. It really doesn't matter if the doctor evaluated the neonate 5 times or stood at the bedside for 10 hours. It is a single daily code.
Moving right along to Section 2, Pediatric Critical Care Tiers and what happens when patients age up.
Take a look at this breakdown. The CPT guidelines are super strict about segmenting these patients by age. For critically ill infants from 29 days of age up through 24 months, you report 99471 for the initial day and 99472 for subsequent days. Then, for young kids aged 2 through 5 years, you shift over to 99475 for the initial day and 99476 for subsequent days. But here's the massive takeaway you absolutely cannot miss. Notice how we stay on these daily global codes up through age 5. But the absolute second that pediatric patient turns 6 years old, boom, you are completely done with per diem codes. For any critically ill patient 6 years of age and older, you transition immediately back to those standard time-based adult codes we all know, 99291 and 99292. Age is everything here.
Next up is Section 3, Weight-Based Intensive Care and Stepping Down Acuity.
Guys, listen up, because this is where a lot of coders trip up and make some really costly mistakes. When a patient's status drops from critical care down to continuing intensive care, your entire coding driver flips. This is a profound shift in logic. You go from selecting codes strictly based on the patient's age to selecting them strictly based on their present body weight.
Let's break down exactly how this works. For the initial day of intensive care for a neonate, meaning they need heavy observation and frequent interventions but they aren't critically ill, you use code 99477. Simple enough, right? But for all subsequent days of intensive care, look closely at these tiers. You have to select codes 99478 through 99480 based strictly on the infant's present body weight that specific day. Under 1,500 grams gets 99478. 1,500 to 2,500 grams gets 99479, and over 2,500 grams gets 99480. And the magic word here is present. If an infant gains or loses weight and crosses one of these thresholds, your code has to change to match their weight on that exact date of service. No exceptions.
All right, Section 4, Critical Care Transport Services.
So, before these vulnerable patients even make it to the unit, they often need specialized transport. For critically ill kids who are 24 months of age or younger, CPT gives us 2 completely different sets of codes, and it all boils down to where the physician actually is. If the doctor is physically right there in the transport vehicle, giving hands-on, face-to-face care, you're looking at 99466 for the first 30 to 74 minutes and 99467 for extra time. But if the physician is back at the hospital directing a specialized transport team remotely over a radio or phone, then you report the non-face-to-face supervision codes, 99485 and 99486. You can never, ever report these 2 code sets together for the same physician. It's strictly physical presence versus remote medical command. Moving on to Section 5, Bundled Procedures and Status Transitions.
Remember earlier how I kept harping on the fact that neonatal and pediatric critical care codes are per diem global codes? Well, because they pay out a comprehensive daily rate, that rate already includes a whole bunch of inherently bundled procedures. We're talking CPAP, endotracheal intubations, placing umbilical arterial or venous lines, giving surfactant, lumbar punctures, even blood transfusions. The CPT rulebook is crystal clear on this. If you are reporting a neonatal or pediatric critical care code for a physician, you absolutely cannot bill these procedures separately on that same day. Facilities can sometimes report them, sure, but the professional physician coder cannot. It's a package deal, baked right into the global code.
Now, you might be wondering, what about a rapid deterioration scenario? Say a baby is born, everything looks fantastic, so the doctor bills normal newborn care, like 99460. But a few hours later, on that very same calendar day, the newborn crashes and the physician has to assume critical care. How do you code that? Well, you actually report both. You bill the initial critical care code 99468, but you absolutely must append modifier 25 to that normal newborn code 99460. That tells the payer, hey, this was a significant separate service that happened before the baby got sick. It's a lifesaver for getting fully reimbursed.
And finally, Section 6, which you definitely don't want to skip. Top audit red flags and compliance guardrails.
I really want you to take a hard look at your own charts and ask yourself honestly, are you accidentally triggering an audit right now by mixing up these age and weight rules? Because auditors are out there actively hunting for these exact slip-ups.
Here are the biggest red flags they're looking for. Number 1, reporting those hourly time-based codes, 99291 and 99292, for kids under 6 years of age. Unless they have had their 6th birthday, you have to use the per diem codes, period. Number 2 is aggressive unbundling. If an auditor sees a daily critical care code billed right next to a separate charge for CPAP or a lumbar puncture, that's practically an engraved invitation for an overpayment takeback. And the third one, which is honestly the most common trap, mixing up birth weight with present body weight. For subsequent intensive care codes, 99478 through 99480, you can't just copy-paste the birth weight. You have to verify what that baby weighed on that specific day of service. If they were born at 1,400 grams, but now weigh 1,600 grams, they just moved up a tier. If you build a birth weight anyway, your coding is non-compliant, plain and simple. Look, getting this stuff right is absolutely crucial to protecting your practice from audits, while ensuring you're fairly reimbursed for complex care. So I want to leave you with this thought. What guardrails does your facility actually have in place today to catch that birth weight versus present weight error before the auditor does? It's definitely something to think about. Thank you so much for joining me on this explainer. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.